Someone reaches down to pick up a bundle of dry firewood. Suddenly, a snake strikes and quickly slithers into a rock crevice. All that remains on the victim's hand are two small, oozing drops of blood, a spreading sharp pain, and a fleeting memory of the animal's color. Panicking, the victim stands up, intending to sprint back to camp for help. But immediately a companion holds them back. They call for others, lay the victim down, and begin their checks. They listen to the person's speech, monitor their breathing, and observe the swelling and bleeding. A makeshift stretcher is brought over. In those tense first minutes, nobody knows if this is a harmless bite, a dry bite, or the beginning of a severe envenoming. Before humanity invented anti-venom, what could people do during that window of time when the venom had not yet revealed what kind of threat it would become? In those initial minutes, the core problem was not finding a secret herbal antidote. The real issue was avoiding turning an unknown amount of venom into a massive crisis simply through running, panicking, and improper treatment. The questions usually asked about history are what kind of leaves they used, whether they sucked the venom out, or if they burned the bite. But the more accurate questions are whether venom was actually injected at all. Is it attacking tissue, the bloodstream, or the nervous system? Can the victim breathe on their own? Is the swelling and bleeding getting worse? Who will carry them? And can the group provide continuous care for several days? Ancient medicine may have changed the circumstances around the victim much more than it actually altered the venom molecules already circulating inside the body. The ability to provide that care depended entirely on the type of bite, because the same two fang marks could lead to four completely different biological outcomes. The first and luckiest scenario is a bite with no venom. This could be from a non-venomous species or a venomous snake that simply did not inject venom, commonly known as a dry bite. The victim will still feel pain, bleed, swell, or even develop an infection at the wound, but they will not develop systemic envenoming. The frequency of dry bites varies depending on the species, and no one can assume it is a dry bite the moment it happens. The second scenario occurs when the venom primarily attacks the nervous system. Certain venoms can cause drooping eyelids, muscle weakness, difficulty speaking or swallowing, and most critically, respiratory paralysis. The victim might remain fully conscious but become completely unable to breathe on their own. Today, continuous airway and breathing support is mandatory. But the vast majority of ancient societies had no way to maintain effective, prolonged respiratory support. The third scenario involves venom that causes coagulopathy or internal organ damage. Some bites trigger spontaneous bleeding, internal hemorrhaging, severe drops in blood pressure, or acute kidney injury. Prehistoric people had absolutely no means to observe or evaluate the blood clotting process happening deep inside the victim's body. The fourth scenario is when venom causes severe local tissue destruction. Symptoms can include agonizing pain, massive swelling, blistering, necrosis, loss of limb function, and secondary infections. A person might survive the bite, but they would require weeks of care and could be left with lifelong disabilities. Even today, the number of amputations and permanent disabilities caused by snake bites vastly outnumbers the fatalities. There is an incredibly common misconception that snake venom just sits right at the two fang marks. In reality, as soon as it is injected into the tissue, the venom begins distributing through the lymphatic and circulatory systems. Cutting or sucking at the surface of the wound does not guarantee the retrieval of any meaningful amount of venom. Instead, it creates the risk of muscle damage, massive bleeding, and infection. Another disastrous misconception is the belief that tying a tourniquet as tight as possible will trap all the venom. Tight arterial tourniquets can cause ischemia, increase tissue necrosis, create a risk of shock upon removal, and offer no reliable benefit whatsoever. The third, and perhaps biggest misconception, is the belief that if a victim survives, it proves the remedy worked. A victim might survive simply because it was a dry bite, a low venom yield, a less toxic species, their own robust health, or just natural recovery. This is exactly why completely ineffective remedies could be passed down through generations on the back of glowing success stories. Because ancient people did not know which biological path they were facing, the safest system had to begin with actions that would not harm either the mild or the severe cases. The first layer of defense was avoiding a second bite. Immediately after the strike, the group had to get the victim and helpers out of the snake's striking range, absolutely avoid trying to catch the animal bare-handed, and prevent others from stepping into that same rock crevice or bush. The greatest risk in that moment was not just the injected venom, but having a second person bitten while trying to kill or identify the snake. The second layer of defense was turning the victim from a pedestrian into a passenger. If the victim had to run or hike a long distance, their muscles would work hard, elevating their heart rate and blood flow, which accelerates the spread of venom. Furthermore, they could trip and fall once dizziness or muscle weakness set in, prolonging the time it took to reach safety. An ancient community could use human strength to carry them, craft a stretcher from branches, or even set up a care spot right there. The most important person after a bite might not have been the healer, but the people strong enough to carry the victim back to camp. The third layer was keeping the victim's limb and body as still as possible. A simple splint could restrict muscle contraction, reduce the pain of movement, and prevent the victim from constantly squeezing or inspecting the bite. Even without an understanding of the lymphatic system, practical experience likely taught them that people who lay completely still often deteriorated slower than those who kept moving. The fourth layer was observation rather than constant intervention. The care group could monitor obvious physical changes. Is the swelling spreading? Is there bleeding? Is the victim vomiting, growing weak, having trouble speaking, struggling to swallow, or changing their breathing pattern? Careful observation allowed them to assess the situation without needing to aggressively handle the wound. The fifth layer was maintaining posture and protecting the airway. A weak or vomiting victim can easily choke, aspirate vomit, or have their airway obstructed by their own soft tissues. By keeping the victim's face and mouth clear, placing them in the recovery position on their side, monitoring them constantly, and waking other caregivers if the victim's breathing grew faint, they could prevent death by asphyxiation before the venom fully took its toll. The sixth layer was protecting the wound without causing further tissue destruction. They could shield the bite from dirt and insects, prevent friction on the damaged area, and replace soiled materials. However, if they decided to apply dirty mud, make deep incisions, poke multiple holes, burn the bite, or tie a tight tourniquet, they would inadvertently introduce countless dangerous complications. The seventh layer was managing temperature, safety, and dependent needs. An immobilized victim needed shade in the heat, warmth in the cold night, protection from the rain, and guards against predators. They also needed others to look after their children or take over their daily chores. This was a form of social care, not an anti-venom. The eighth layer was calling the right person with experience. A seasoned healer brought value that went far beyond their remedies. They could help identify the snake species, know which bites typically caused swelling versus paralysis, recall which past cases survived, recognize the symptoms of a poor prognosis, organize the caregivers, and decide when it was necessary to move the victim. The final layer was recognizing human limits. If the victim lost the ability to breathe independently, bled systemically, or suffered circulatory failure, kidney failure, or rapidly progressing widespread necrosis, ancient communities generally lacked any specific means to reverse the process. Supportive care could keep some people alive, but it could not magically turn every lethal dose of venom into a mild illness. This system shows what they could do physically, but the most direct evidence of how an ancient society thought about snakebites lies in a papyrus scroll, and it reveals the blurry line between observation, medicine, and magic. Historically, dry bites are the reason why many misguided remedies maintained a stellar reputation. Imagine a healer treating 10 people. Some are bitten by non-venomous snakes, some get dry bites, Some receive very low venom doses, and a few receive lethal doses. Many of those first patients will recover completely regardless of the treatment used. The community will only remember that the healer arrived, the medicine was applied, the spell was chanted, and the patient lived. It is very hard for them to observe the true variable, the fact that little to no venom was actually injected. These survival stories created a massive survivorship bias. Survivors could proudly boast about the remedy, while the dead could not explain that the cure completely failed. A treatment can appear highly successful when the nature of the bite itself was inherently mild, rather than due to the efficacy of the method. However, the Egyptian Brooklyn Medical Papyrus, dating from the 7th to the 4th century BCE, turned snakebite management into a genuine diagnostic system. This is the earliest known structured treatise on snakebites. The scroll names 24 snakes and 1 chameleon, detailing their appearance, habits, the bite marks they leave, their effects on the victim's body, and then provides a prognosis and treatment plan. This was an incredibly important cognitive leap. The Egyptians understood that not all snakes are the same. Symptoms indicate the danger level, and some cases naturally have a much better prognosis than others. Their strongest weapon may have been classification, knowing that some bites just needed to be watched, while others signaled rapidly narrowing odds of survival. In practice, Egyptian medicine utilized onion, natron, incisions, bandaging, plant materials, and magico-religious elements. Incising the bitten area might have been intended to release fluids or remove poison, according to the beliefs of the time. However, from a modern medical perspective, an incision cannot retrieve venom that has already spread, and it runs the risk of severing nerves and blood vessels, increasing bleeding, and introducing infection. Bandaging might have simply been used to hold medicine in place or cover the wound, rather than acting as a tight tourniquet designed to stop blood flow. Remedies made from herbs or minerals might have dried the wound, reduced odors, or acted on the surface, but they could not reverse paralysis or kidney failure. Ancient medicine combined careful observation with treatments that were practical, symbolic, sometimes ineffective, and even harmful, all within the same protocol. Looking broadly around the world, herbal antidotes often possess chemical potential but lack practical clinical efficacy. Many traditions use leaves, roots, bark, or decoctions to treat snake bites. Certain plant compounds in a laboratory setting can interact with venom molecules, but moving from that to a life-saving human treatment is a massive leap. To date, ethnobotany has not provided any plant-based antidote proven to completely replace antivenom. A plant can contain an interesting molecule without being a safe, fast, or effective treatment for a person already envenomed. The most crucial part of the treatment process was often the supportive care, the part that never leaves behind any archaeological artifacts. One person sitting awake to watch the victim all night, 2 people carrying them on their backs, someone else taking care of their children, or the victim being repositioned when they vomit. None of these actions create an excavatable snakebite artifact. But in cases of mild or moderate envenoming, it was exactly this social care that gave the victim's body enough time to recover on its own. In severe cases, it might have only prolonged the inevitable or reduced suffering, but it was the most effective response a community could provide using their own time, attention, and labor. A snakebite creates an invisible but incredibly intense pressure that forces people to act immediately. When they cannot see the venom seeping into the body, people have a strong urge to cut, suck, bind tightly, burn, apply harsh substances, or force the victim to drink something. A painful intervention often creates a much stronger feeling that they are actively fighting the venom compared to simply letting the victim lie perfectly still. But the cruel twist is that the most dramatic methods usually targeted the wrong place. Cutting deeper only created more tissue damage, triggered massive bleeding in individuals already suffering from coagulopathy, and cost victims the function of their hands or feet. Modern medical reviews show absolutely no survival benefit from cutting or sucking the venom out. Sometimes, a cure inadvertently created a brand new disease. The victim then had to suffer not only from toxins, but also from tourniquet-induced ischemia, knife wounds, burn injuries, herbal poisoning, and the risk of infection. When the victim died, it was very hard to know which factor contributed the most to that death. Religious rituals could help keep the victim still, reduce panic, and bring experienced healers to the scene in time. But they became harmful if they replaced actual transport, required the victim to walk long distances to perform a ceremony, or delayed the critical observation of the respiratory system. A survivor could become the greatest piece of false evidence. When a person recovered from a dry bite thanks to a poultice or a chanted spell, the community would copy and repeat that entire sequence of actions for the next victims, never knowing which element was actually unnecessary. That is how coincidence became an oral medical protocol. Severe envenoming cases reveal the absolute limits of ancient medicine. If the diaphragm was paralyzed, resting was not enough. If the blood would not clot, an external bandage on the wound could not stop internal hemorrhaging. If toxins destroyed the kidneys, topical herbs could not replace dialysis. The greatest achievement of ancient healers was not necessarily curing the most severe case. Perhaps their true greatness lay in knowing exactly which cases they should not interfere with to avoid causing catastrophic harm. But even the argument for doing less must be approached with caution. Modern medicine tells us what should be done today, but it does not automatically prove that prehistoric people knew or practiced it. There are no fossils that can specifically confirm a death by snakebite. A person who died of respiratory paralysis or kidney failure from snake venom would leave behind a skeleton indistinguishable from many other causes of death. We also have no direct evidence that prehistoric people knew how to immobilize victims. The World Health Organization recommends immobilization and transport. That makes similar behavior in the past highly plausible, but it does not turn it into an obvious archaeological fact. An ancient community could improve survival odds by stopping the victim from walking, but we cannot claim they understood the lymphatic system. Furthermore, ancient Egypt, with its Brooklyn Papyrus, does not represent all ancient peoples. They were a literate society with medical specialists and a distinct academic tradition. Hunter-gatherer groups elsewhere might have possessed entirely different bodies of knowledge. The lack of a proven herbal antidote does not mean all plants are useless. Certain plants can reduce pain, lower inflammation, or act as antibacterials. However, providing symptom relief and neutralizing venom are two completely different categories. These limitations make the modern narrative even clearer. The decisive breakthrough was not finding a stronger herbal trick, but connecting victims faster to specific treatments and respiratory and circulatory support. The echoes of history are still strongly felt in the modern world. Today, snakebites still heavily impact people who work outdoors, in areas far from hospitals, with limited transportation, scarce equipment, or anti-venom, and where traditional treatments are still used before seeking medical facilities. Delays in accessing treatment remain a leading factor in increased mortality and disability. Ancient and modern logic meet at one exact point. The victim doesn't just need a medicine. They need an entire system to get them to that medicine without making their condition worse. The difference in the modern world is that we have anti-venom to neutralize toxins, ventilators to maintain breathing, dialysis machines, and surgeries to handle long-term damage. Most importantly, modern medicine has definitively discarded cutting, sucking, tight tourniquets, and unproven remedies. When a disease creates extreme fear but lacks visible information, humans easily judge an action based on its dramatic flair rather than its actual efficacy. Please note, if a real-life snakebite occurs today, it is imperative to immediately call emergency services and transport the victim to a medical facility. Absolutely do not apply the historical treatments mentioned here. So, Returning to the victim in our opening scene, the honest answer isn't that they had a secret antidote. It's that they could create time, and sometimes the venom dose allowed that time to be enough. The victim does not have to walk. The group carries them to a shaded, safe place where someone watches them constantly. The bite is covered but not cut further. A healer carefully observes the swelling, their voice, their eyes, their breathing, and any bleeding. Others take on the duties of caring for the children, foraging for food, keeping the fire going, and taking shifts to stand watch. Through the night, the victim continues to breathe on their own. The swelling stops spreading. They live. After a snakebite, ancient people could move the victim out of danger, stop them from moving, carry them to a place of care, keep their body as still as possible, observe every change, protect the wound, and maintain that care for days. Some societies possessed specialists who could identify snakes, provide a prognosis, and combine bandages with plant remedies and rituals. However, these measures truly only saved those who received dry bites, low venom doses, or envenoming mild enough that the body could overcome it on its own. They were not reliable means to reverse respiratory paralysis, massive hemorrhage, or kidney failure. The history of snakebites often focuses solely on the herbs, the spells, the cutting knives, or the pressure bandages. But the decisive factors were sometimes much more invisible. The person who stopped the victim from running, the shoulders that carried them back to camp, the eyes that stayed awake all night watching their breath, the hands that cared for their family in their place, and the amount of venom the snake did or did not inject into their body. Ancient care could protect the patient's breathing, movement, and damaged tissue, but it could not reliably neutralize venom already circulating through the body.